Let's be honest, modern medicine is broken. Patients are dismissed, doctors are exhausted, and mental health care is decades behind. So it's time to disrupt the status quo, to challenge a system that fragments care, dehumanizes patients, and burns out clinicians. I'm Dr. Georgine Nanos, and this is The Kind Revolution, a podcast about breaking old paradigms, rebuilding medicine with compassion and science, and reimagining what healthcare can be when we finally get it right. Because change is here, and it's starting with us. Welcome to the revolution. Welcome back to the Kind Revolution podcast. I'm Dr. Georgine Nanos, and today we're diving into a conversation that touches every family in some way, and that's cancer care, survivorship, and the human side of oncology. My guest today is the outstanding, amazing Dr. Anjali Bharne, a board-certified hematologist and medical oncologist at University of California, San Diego Health. Dr. Bharne treats a wide range of cancers from breast and lung to gastrointestinal, urologic, and hematologic malignancies, as well as benign blood disorders. She's conducted important research on lung cancer and cancer-related fatigue and brings both scientific rigor and deep, deep empathy to her work with patients. We are so grateful to have you with us today, Dr. Bharne. You are also a close colleague and friend of mine, and we've shared so many, I think hundreds and hundreds of patients over the years. So I'm excited to have this conversation today.
Thank you, Georgine. It's really nice to be here and talk to you.
So tell us, I think oncology is probably one of the most challenging specialties, and I think the general public is in awe of how oncologists can do this job. Tell us how you got here. How did you become interested in oncology? What took you to this path?
I think too, for those of us in medicine, it's like we know that it's a long road. So when we're on this road, it's like we're pretty much motivated by, for me, it's something. And for me, it's just compassion for patients and empathy and just combining that with medical knowledge and being in that unique position to be able to help or comfort someone when their health is, serious issues. In terms of what took me, actually, my parents are physicians, my brother's a physician. And so I actually was thinking I would go on a different path. And then I discovered anatomy in high school. And I took an anatomy class. I thought that was so interesting because that applies to all of us and learning about the human body. And when I was doing my next phase of training at Cedars-Sinai in Los Angeles, I rotated on the bone marrow transplant ward, and patients there are staying can be like, weeks, if not longer, for their stay. And you get to develop a relationship with the patients because you round every day on that ward, and you got to know them more and being able to explain to them the medical side of things and hopefully assuage some of those fears. It was a really, really rewarding feeling. I think it was because of that length of relationship. So then I thought, oh, this is what I want to do.
You've been in practice now, how many years?
Since 2010.
Okay,
so I guess 15 years.
15 years. How has cancer care evolved in the last 15 years? What are some of the promising advances that you've seen compared to where we were 15 years ago?
I think there's two things that kind of stand out to me. One is taking the chemo that we've known and trying to figure out through different clinical trials, is 2 drugs better than 1 drug? Is 3 drugs better than 2 drugs? And trying to figure out what's the best that we can offer patients, basically building on the chemo and trying to use it most effectively. The second thing that I think is really, really interesting is learning more about the mutations that we see with different cancer types and trying to use drugs to target those mutations. So like precision oncology is one of the words that we use, trying to understand the molecular features of each person's cancer to then use drugs to target that. So I think those are 2 big advances over the last decade. And I think the other thing is immunotherapy. I have patients asking about these drugs. Basically, these are IV drugs, infusions, or injections, but they're a kind of a newer, in the last decade, class of medicines that are trying to use the patient's immune system to fight the cancer. So the oversimplified explanation, because it's very scientifically complex, but oversimplified, is taking the brakes off someone's immune system to use the immune system to fight cancer. So that has been a huge advance in different cancer types.
Yeah, and we've certainly seen that with a lot of our mutual patients too. When patients get that first diagnosis of having cancer, obviously it is a jarring and shocking event. And when we're guiding them as to treatments, what are some of the biggest concerns and things that you hear from families about chemotherapy or cancer care that you see in those initial visits so that you can help our audience maybe better understand if they're in this situation for the first time, what to expect and what that looks like on your end?
So when I see a patient for the first time, it's usually they've been given a diagnosis by a doctor before me. And so when they get to me, they know usually what the cancer is. So I can take the conversation from there. I'm then focused on we know this is what it is, and now we want to understand the extent of the cancer, which is the blood test we do to assess the stage, which means the extent of the cancer. And then once we've assessed the stage of the cancer, then we can address the next, what a treatment plan could look like. When we get to those conversations, those first couple visits are very just a lot of information coming at someone. What we focus on once we've established a treatment plan, our first thing is to understand, are we in a curative setting, or are we in a metastatic or non-curative setting, what we call a palliative setting. So then once we've made it best clear we can what our goals are, then we kind of outline what a treatment plan looks like. And the main concerns, as we could expect, how long is it going to be? Meaning, is it going to be 6 months? Is it going to be lifelong? The side effects in terms of how am I going to feel, or my family member going to feel? But when you asked about what's changed over the last decades, it's also been the supportive care that is there for these side effects from chemo. So things like our nausea medicines are better. We have more nausea medicines. We have patients come in for IV fluids and give them IV nausea medicines. I try to reassure patients that we will support them through those kind of symptoms, especially.
Back to this notion, this kind of vision that people have of chemo from maybe 20, 30 years ago that kind of has been stuck in the American psyche of what it looks like with TikTok and Instagram. There's this kind of dichotomy that people want to do something natural instead of being poisoned by chemo. And you and I have had this conversation so many times. In fact, we've even had we've watched patients who could be cured by cancer actually die because they made these choices based on things that they see online on TikTok and Instagram, that, going natural is safer and more effective than evidence-based care. You and I see this so often, and I've lost friends and patients to this phenomenon. And I'm trying to understand like where it comes from, how we can help dispel these myths. What's your take on this?
I think you're right. It's a really complex and layered. It's so layered because it comes back to patients' experiences with family members too, or friends they know, or people they know. So the experience of a family member or a friend completely can color the perspective instead of looking at the clinical trial data that shows a benefit to these things. And you and I know that clinical trials are pretty rigorous. Like when people are on a trial, there is a lot of testing and a lot of assessments and a lot of really attention to these clinical trials so that when the results are looked at, there's often like, this is the purest kind of information we can get about whether or not a treatment works or doesn't. And it does take a significant amount of data usually to get something approved by the Food and Drug Administration. So to have a drug approved at that point, my point is saying that there is data behind it. So there's strong data. So when a patient experience or choice about chemotherapy is colored by the experience of one person they know or in the community, it's hard for me as a doctor who's looking at the data that sees the benefit of these things. I think it's always a place of understanding where a patient's coming from, because I've had some conversations that start with, nope, I'm never going to do chemo. The curative setting, there's data to say that using chemotherapy in some cancer types, stage 3 colon cancer, certain stages of breast cancer, for example, lung cancer, it reduces the chance of the cancer coming back. So the chemotherapy there is not taking a 20% chance and making it zero. Like that's unfortunately, we wish it was the case, but unfortunately, that's not how it works. So we reduce the chance of the cancer coming back. And the thing is, we don't know for which patients like the chemo is really needed. Our testing isn't that sophisticated, meaning to say with patients with stage 3 colon cancer, who's going to need chemo, who's not. We have to treat patients or offer treatment to patients in general with stage 3, for example, stage 3 chemotherapy. Those first conversations, patients will say to me, nope, I don't want to do it because so and so in my family or so and so in the community had a negative experience. Then I say, okay, no problem, just think about it, take the information, digest what I'm saying, talk to family, and then let's reconvene and have another conversation about it and what your specific concerns are. So then if their concern is about neuropathy, like if a family member had neuropathy, I can explain to them, well, this is something we monitor. We sometimes now talk about doing wearing frozen gloves or cold gloves during chemo to reduce the chance of the neuropathy of the hands and feet, because it's some of it shows that if the blood vessels are constricted, then the chemo doesn't get there and doesn't cause the neuropathy. So there's certain things we can try, understand their perspective, make sure they understand what the recommendation is, and do my best to address their concerns accurately, like realistically, because certain things, it is hard for me to say that's just not going to happen, like tiredness. But otherwise, I think hearing where they're coming from, like what family members and how many, sometimes I can understand if there's a place to explain the science behind it.
So much of cancer care is now, I mean, and has been for the last decade, I'd say, focused on integrative care, but that means something different to different people. And I feel like we're moving towards this world where there's almost this dichotomy of like you're either going to do it all natural or you're going to do it all like, with all chemo, and it's just not that way. Like the two worlds can coexist, and they should, because that is what integrative care is. But I think in the general public, the mindset is that you're kind of going one way or the other, and unfortunately social media has created this bigger divide that makes it so that, like, I don't know, that you're choosing one path and it's good or bad for whatever reason. And I think a lot of doctors you have a hard time kind of marrying those concepts. But I have actually been in patient visits with you, and you are so outstanding with patients in kind of hearing them and being so empathetic. How do you do that?
Thank you for the kind words. I would say that I think the situations that you and I have shared in the have been in the metastatic setting too. And the metastatic setting is trickier to me because that by metastatic, I mean the cancer has spread to a distant organ and the treatment intent is typically non-curative. So the treatments we're giving are trying to help someone maintain a quality of life and trying to help them live longer, but it's not necessarily curing. So I think it comes from a place of like empathy, like especially for some of our younger patients. Like we're saying that we have treatments to offer, but they're not going to cure. And they're not even 100% response rates, in terms of getting cancer in that setting under control. So they look to other things. So it's interesting when you say, I agree with you, integrative means different things to different people, because at UCSD, there's an integrative medicine side, and there's things like meditation and yoga, and I'm blanking, but there's other things that have been looked at to help with our version of integrative medicine. Then there's other signs of integrative medicine out there, which are different kinds of infusions, different treatments that haven't necessarily had that clinical trial data behind it that's rigorous, that's gotten drugs approved kind of data. So I feel like there's different kinds of integrative medicine, but I'm trying to always keep in mind what a patient what a patient feels. And our biggest concern, as you and I know, is that if we're doing a traditional like oncology medicine that has the data behind it, we don't want that result jeopardized by the introduction of integrative outside infusions of other things. So I think this is a very tricky topic in the metastatic setting, because I can see why patients want to look at other things. But if they're pursuing a treatment that's FDA approved or what we call standard of care, we're worried about jeopardizing the effectiveness of it with going with integrative stuff in addition, but also if there's going to be more toxicity or side effects. So it could be a lose-lose situation. So that's because of that unknown. We ask patients to not necessarily pursue things at the same time if they're going with outside infusions. There's also the issue of monitoring if they do choose to do that, because we can't control what patients do outside of our office. Then when we have abnormal results, we don't know what's causing what, with liver tests or something like that. So it can introduce a lot of confusion to a standard treatment program, but I can understand how patients look for something else. And again, it goes back to the anecdotal piece for patients. They hear a family member or community member who's had a good experience with something, but the problem with cancer, and in their same situation, the problem with cancer is we all know everybody responds differently to treatment. So then those same situations can't be applied to the person I'm sitting in front of. So I understand why, but I would say that to jeopardize a possible result we could get or to avoid toxicity, it doesn't seem compatible. But I try to be understanding when I'm seeing patients.
Yeah, and cancer is different. Not only does everyone respond differently, but every cancer is entirely unique, really, to that individual. So that's the other part that I think is lost on people. One isolated anecdotal incident doesn't necessarily capture it for everyone. What makes me sad as a physician and as a human for these people who are at the end of their lives and really like struggling is that they a lot of times they fall for what are, clearly scams. um Taking tens of thousands of dollars from people to like offer these promises of cures, and it's devastating to see. I know you've seen this too. Like, how can we help people like understand how to avoid these traps?
It's tough to look at. And I think it goes to us. One of the things that boggles my mind is that these treatments, as you said, are out of pocket. So to pursue something that's out of pocket means that there hasn't been approved by the FDA and for that reason. So if that's the case, then there's not enough rigorous data behind it. So it kind of surprises me when patients are wanting to pay out of pocket for something that's not rigorously proven. And the things that are rigorously proven, I'm not saying work for everyone, but at least have the data to support its use, are the things that are covered by insurance. As a medical professional, paying for something out of pocket that doesn't have a clear proven benefit, I just doesn't make sense to me, because it's like that's exactly where we know that it may or may not work. And it's like the financial toxicity of that, separate from like
Right.
the physical toxicity if it causes any side effects. So I think that for me, it's the point one, helping a patient understand that if it was proven, it would have been typically covered partly by insurance. I'm not saying fully, but at least partly by insurance. The second thing is I have seen, and I'm not saying it's common, but I've seen toxicity from certain infusions. So I tell patients about that, because you and I have probably patients ask us about high dose vitamin C and or pursue it. And I've seen toxicity from that when I was at Cedars. So it's something that and there's no data in our oncology world. It's not part of any guideline to pursue that. So I tell patients that as well. After that, it's the infusion, these alternative providers are there. I'm going to go spend large amounts of money to do this.
At market, I think these people are excellent at marketing themselves. Another really interesting pattern that I've noticed, because I um I've seen this so much over the last 20 years, is a lot of these outside providers who are offering these treatments either are not medical or they're not MDs or not licensed, or if they do have if they are MDs, oftentimes they have lost their license or have had something, they have some issue with their license. So I think as we're talking about this, one caution for the general public is to do your research on the credentials of these people, because more often than not, these individuals have lost their license or have had some suspension or something weird going on, and that I see that quite a bit. I don't know if you've noticed that at all.
And I'm not as familiar with the providers that are doing it, but I think what I've been surprised about is it's like there's multiple centers. So I think in the past, like there used to be one or two providers, and now it seems like it's more prolific. which then it surprises me even more as a like an oncologist. It surprises in the sense of, wow, like, like you said, people must feel really looking for something else, whether it's because of the concerns they have about traditional, like FDA approved medicines or what we call standard of care, or because someone had a positive experience and they're extrapolating that for themselves. My concern is that, just like we already highlighted, cancers are different, patients are different, and someone else's experience that might have been positive, it doesn't apply to the person sitting in front of me. What applies to the person sitting in front of me is what is the data behind the things I have to offer that patient. And alternative medicines are not, until they have the data behind them, they're not there. So I think it just supports the fact that patients are just looking for something else. Sometimes, Georgine, I feel like patients go through what they want to. Like I had a patient in the past 7 years ago or something who wanted high dose IV vitamin C. I kept explaining to her, there's no data, I don't recommend it. There's no data, I don't recommend it. And she was like, I guess from family had told her that you need to look for this, you need to do it. So listening to family, she did it. Thankfully, she didn't have any sort of physical toxicity, but she just came back after I don't know how many weeks or months of doing it. She's like, Dr. Bharne, she's like, it wasn't making a difference in my scans. And I'm like, it became so expensive to her that she's like, I'm just not doing that again. And so she had to kind of go through it to
Yeah.
realize it just didn't make sense anymore. And that's what we were trying to save her, that financial expense.
Right. Some of these people with no medical expertise have these massive platforms and just kind of say whatever the hell they want. What on earth do you say to that?
I had a really sweet patient once who had been taking it without sharing it with me for his metastatic cancer. And one visit, he just kind of felt like he had to confess to me. And I thought he was going to tell me something like something really concerning or bad about his personal life. And I was ready to support him and listen. But then he said, I had to get this off of my chest. He's like, I've been taking this ivermectin and fenbendazole for the last some months, and da da da. And he's like, whew, he's like, I feel so much better telling you. And I said, okay. And I felt bad that he was holding it in for so long. I just felt bad for him as a person that he had this secret that he wasn't telling me. But then I also said, okay, he told me, he gave me 4 separate anecdotes, Georgine, in detail of the benefit to someone else about this. And some of them were his cancer type, some of them were a different cancer type. So when he told me that, I said, well, I'm glad you shared that with me, because it just helps me understand your blood test. It helps me understand where you're coming from. I would say that my advice to you is that there's no data to say it's going to help here. We need to go down a certain pathway, like for the cancer that you have, and that need, meaning this is what would be recommended by standard of care. He then responded and said, I like the results we've had so far. I want to keep going with the ivermectin and fenbendazole and then come back and see you. And I said, okay, in the sense of he wasn't taking any chemo from me, he was doing that. It was, how I just explained about that IV vitamin C. He had to go through it. He went through 2 months of it. We did a scan. So my trade-off was, we can try it your way. We can, go down the path that you want to go, and we'll scan sooner than we would normally, so I can make sure nothing's growing. What happened is no surprise to you and me, Georgine, but the cancer did grow, and it was growing rapidly at that point. When we tried to put the chemo back on, it didn't give us the same benefits as it had before. So I tell patients that when we try to go down these other pathways that aren't proven, it's of course a patient's choice what they want to do, but this isn't like a science experiment where we can control all the variables. Unfortunately, the body isn't like a science experiment where we can control all the variables as tightly. And it's also because it just speaks to the complexity of the human body too, and cancer as well. So when we retried the same chemotherapy that had given us results maybe 6 months before, there was no response. And so he just was frustrated with himself for taking the break to do
Yeah.
the alternative treatment. But he also, despite what I was saying, was taking that break to do the alternative treatment. And it wasn't because he was experiencing side effects from the chemotherapy. It was the power of the anecdotal experiences from the family members, the community members. So it one thing I'll say is that family and community, they sometimes feel that they're helping a patient when they share stories of positivity with these or anecdotal things that happen.
Yeah.
But the problem is that sometimes it actually pulls the patient away from, oopsie, sorry, it pulls the patient away from a treatment that could help them. Sorry, do you need me to
Right.
say that again?
Right. And that's the thing. No, that's true. And cancer doesn't wait. This is the thing that I think people don't understand. It's not going to wait for you to do this little side experiment that is,
Yes,
probably not going to be of benefit to you. Obviously, having a cancer diagnosis is a devastating experience, but seeking out oncologists like yourself who have the empathy to listen and hear.
I think that is really important with this diagnosis, especially like you just said, because it's such a complex diagnosis, and it is such a thing that we could give multiple people the same treatment, and some people will respond and some people won't. So there's clearly things that we don't know about, like obviously about cancer treatment. Otherwise, as we all say, we wouldn't be dealing with it and everybody would have 100% cure rate. So knowing that, I think finding a doctor that understands where someone's coming from, but makes it, my goal is to make it really clear what the recommendation is. So patients don't leave confused about, I could do this or I could do that. This is the recommendation. If someone wants to pursue something else, then having a discussion about why they want to do it, what they want to pursue. Like you said, it's part of the whole process and it keeps the patient's autonomy.
I know you got to get to your patients, and thank you for spending so much time today. This has been an incredible conversation. Hopefully, we can do it again soon. Thank you for everything that you do. You take such great care of my patients and all of yours. And I just want to thank you again for your time today. It's been such a pleasure.
You're such a thorough and like caring physician, accompanying some of your patients on their visits too. As you've said, you've sat in on some of our like harder conversations. So I respect a lot what you do and the care that you provide. Your patients are also lucky to have you.
Thank you, everyone, for listening, and we'll see you next time.
Thanks for joining the Kind Revolution. If this gave you something real, hope, perspective, or a fresh way to think about health, please share it, subscribe, and pass it on. Medicine won't change on its own, but together we can reimagine it and build something smarter, kinder, and create a system that truly heals. This is the Kind Revolution with Dr. Nanos, where science meets compassion and the future of medicine gets brighter one conversation at a time. Thanks for joining the revolution.